A warm welcome to Dr. Reena's Physiology, which is going to be core, conceptual, and integrated. So let us begin with the very first class and with very first lecture today. I'm going to start with neuromuscular junction, right? Now, why did I take this topic, neuromuscular junction? Because in the near future, I'm going to take basically CNS 1, which we will begin with synapse. What is neuromuscular junction? It is basically a kind of a chemical synapse, right? This topic is very important, so let's proceed. Now basically, what is this neuromuscular junction, which is also called as a myoneural junction, right? It is also called as a myoneural junction. So by definition, it is a junction between the motor axon and striated, that is the skeletal muscle fiber, right? So it is the junction between the motor axon, which will lose its myelin sheath, and it will communicate with the striated, that is the skeletal muscle fiber. Now why do we need this? What is the need of this? See, suppose I have to pick up and write. All these are skilled voluntary movements which begin with cognition, okay? So they begin all the way with a cognitive thought in the mind that I have to do this, which will be processed by different areas of the brain. For example, the planning and programming will be done by basal ganglia, by parts of the cerebellum, by the premotor cortex, and ultimately the primary motor area, that is area number 4. It is going to send this information in the form of the corticospinal tract, which ends up upon the alpha motor neurons. These alpha motor neurons, which have got their cell body in the ventral horn cell of the spinal cord, and they are going to supply your skeletal muscle fiber. So you have to execute a voluntary movement which is done in the form of a command that is originating in the cortex and coming all the way through this tract and terminating on the alpha motor neuron. This will then proceed its work further by the excitation contraction coupling. Now let us take a case history, because you know that now times you get a clinical based question. So let's begin this with a case history. So the history says that there is a 32-year-old female which is complaining difficulty in chewing food, and this is especially with meat. That means where more energy is required for the jaw muscles to chew the food, right? And when she is chewing, the muscles get weak and tired. However, when she takes rest, she gains strength. So this is a very, very typical history that jabhi bhi patient will say that whenever the patient is working more, there is going to be exhaustion or fatigue, but that improves with rest. So that improves with rest is a very important diagnostic clue for the condition associated with NMJ. So I can put over you different questions, okay? For example, I may first ask you what is the diagnosis of the disease. I may ask you what is the ionic basis of the EPP that is developing over here, that is the excitatory or the end plate potential. I may ask you what is the physiological basis of treatment of this condition, or what is the physiological basis of using an ACE inhibitor in this condition. Diagnosis to be provided or not to be provided depends upon the examiner. Now, the must-known competencies with this topic are: you should be able to describe in detail the structure of NMJ, right? That means you should also know a well-labeled diagram. You should nicely be explaining the mechanism, that is the transmission across the neuromuscular junction, and definitely the pathophysiology of the Myasthenia Gravis, right? This topic can be vertically integrated with pharmacology, pathology, and anesthesiology, because when we speak of the various skeletal muscle relaxants, at that time we need to know this topic. So as I told you, that this is the corticospinal tract, which is going to end on this alpha motor neuron, which has got a cell body in the ventral horn cell of spinal cord. This is the axon, which are having very large diameters, and they end up upon the muscle cells, that is the skeletal muscle cells, forming a motor unit, and this portion is going to be your NMJ. So you can see over here, if I just highlight it, you can see over here that this is your NMJ, where the motor nerve endings, they are forming chemical connection with the muscle. Okay, so let's begin with the neuromuscular junction. So when we begin with the neuromuscular junction, remember that it is a type of a chemical synapse, and it will have one presynaptic portion. Between the presynaptic and the postsynaptic portion, okay, so there's going to be a presynaptic portion, there's going to be a postsynaptic portion, and between both of them there is a gap which is called as synaptic cleft. So all these should be coming up in your structure. You should be able to elaborate it nicely. Now this is the structure, the cells, as I told you. If you look into the structure of the axon, you remember that this is the axon and this is the cell body. The cell body, if you remember, they end in the form of these synaptic knobs, or what you called as the terminal buttons. So this is the neuromuscular junction. Yes, okay. So we'll just have a look over the various components of this neuromuscular junction. Yeah. Now the synaptic knob or the terminal button has got very high number of mitochondria. This reflects a high metabolic activity going on. Then there are vesicles which contain acetylcholine. So this again becomes as an MCQ, that what is the neurotransmitter at the level of NMJ? So it is acetylcholine. Present very importantly on this presynaptic portion is something which is called as these dense bar. You can see over here it's quoted the dense bar. What are these dense bar? These are the sites just located near to the calcium channels. So these are the presence of the voltage gated calcium channels. So remember, voltage gated calcium channels are present presynaptically. That is very important, because postsynaptically there is going to be presence of ligand gated channels, and both of these have got different pathologies. So you have to remember that presynaptically, okay, presynaptically there is presence of the voltage gated calcium channels, right? Another important thing is that if you consider, you know, that where these vesicles are present. So I told you that these vesicles are going to be present here presynaptically. They are actually clustered at a particular site which is called as the active zone. So suppose this is the active zone. That means when they are going to be released by exocytosis, they are going to be released through that active site or the active zone. So what do we have? We've seen that there is presence of, yes, there is presence of the presynaptic portion which has got, very importantly, mitochondria, vesicles which are present at the vesicle release sites, which are the active zones. You have got dense bars just located there, will be your voltage gated calcium channels. Postsynaptically, you can see that the postsynaptic portion, which is called as the muscle end plate, and therefore, you know, the potential that develops at the NMJ is called as end plate potential. Okay, it is called as end plate potential. So it is thrown into folds, right? It is thrown into folds. What is the advantage of throwing that postsynaptic portion into folds? It will increase the surface area, right? So the postsynaptic portion is thrown into folds, that is the muscle part, which will increase the surface area. And just beneath this we can see that this is the contractile apparatus, that is the sarcomere, which will be present, right? Now on the postsynaptic site, right? That means on the muscle side there are certain very important receptors. These are your acetylcholine receptors. Now the acetylcholine receptors over here, they are your ligand gated channels, and the ligand over here is nothing but it is acetylcholine. So itna specifically you have to remember that presynaptically you have got voltage gated channels, and postsynaptically you have got ligand gated channels, which are acetylcholine gated channels, and they are called as acetylcholine gated or nicotinic cholinergic channels. You know that acetylcholine has got two receptors, nicotinic and muscarinic. तो यहाँ पे जो receptors हैं, those are nicotinic cholinergic receptors which are present, right? Then how is their synthesis of acetylcholine? This acetylcholine, which is synthesized in the vesicles, is synthesized with the help of the enzyme acetylcholine transferase using substrates choline and acetyl coenzyme A. This acetylcholine is then pumped into the vesicles with the presence of a special acetylcholine hydrogen exchanger, right? The terminal portion of the axons, they are covered with Schwann cells, and those Schwann cells over there are called as teloglial cells. This comes as MCQ. As I told you that the vesicles are clustered in the active zone, and what is the role of calcium? This calcium is going to help in the exocytosis of the neurotransmitter substance, that is acetylcholine, which we will see when we study the mechanism. Now, this is a very important question, that what are docking proteins? You know, what are docking proteins? So, see, this is the presynaptic portion, and suppose these are my vesicles. So we know that these vesicles, they are going to attach over here, and then there will be release of acetylcholine. But there should be a very specific receptor, okay, a very specific protein which will be present on this vesicle, which will bind to a very specific portion on the presynaptic membrane. So this is very, very specific, that this vesicle is having a protein which will bind to a specific protein over here on the presynaptic membrane. These proteins are nothing but they are called as docking proteins, like snare proteins, synaptobrevin, syntaxin. So synaptobrevin is present towards the vesicle, and syntaxin is present towards the presynaptic membrane, right? These docking proteins, when the appropriate docking protein in the vesicle will bind to the appropriate docking protein on the presynaptic membrane, only then there can be release of acetylcholine by exocytosis, right? So a very important clinical association is, you might have had studied, or you will study with your micro, that a patient comes with a history of food poisoning, and immediately after having a meal from some roadside, or went outside and had a meal, there were loose motions and ultimately developed flaccid paralysis. The reason for that is, this is a condition which is called as botulism, that is caused by Clostridium botulinum. This Clostridium botulinum basically interferes with the function of, okay, it interferes with the function of the docking proteins. Okay, that means it does not allow the docking proteins to bind appropriately, and which prevents the release of acetylcholine. And you know that if the acetylcholine is not released, the further processing, that is creation of an end plate potential and then an action potential and then the muscle contraction, cannot take place. So botulinum toxin is associated with flaccid paralysis, and this is the mechanism that it interferes with the functioning of the docking proteins, right? So this is an important condition associated, you need to remember this. As I told you, synaptic cleft is also something to be known. So it is a small space which is present here between the presynaptic and the postsynaptic membrane. So this gap between the presynaptic and the postsynaptic membrane is the synaptic cleft, which is 40 to 100 nanometers wide. The muscle membrane or the muscle fiber is covered with the basement membrane, which contains collagen glycoproteins. The basement membrane in the cleft consists of a very important enzyme, acetylcholine esterase, that is going to bring about the degradation of the acetylcholine into choline and acetate. So once the function of acetylcholine is completed, it has to be removed immediately, which will be done by the enzyme acetylcholine esterase. This means if you want to prolong the action of acetylcholine, or if you want that the duration for which the acetylcholine available is more, you need to give the drugs which will inhibit this enzyme. So this becomes the pharmacophysio integration of the topic, right? So if you want to prolong the action of acetylcholine, give those drugs which are going to increase the duration of availability of acetylcholine by preventing its destruction. Now the postsynaptic membrane, I told you it has got acetylcholine receptors, which are ligand gated nicotinic cholinergic receptors. There are about 15 to 40 million of acetylcholine receptors. That means about 10,000 acetylcholine receptors per square micrometer, wherein each vesicle contains 4,000 to 10,000 acetylcholine molecules. So just imagine when a single threshold stimulus is given, which can release about 10,000 vesicles at a time. That means which can release about 125 vesicles at a time. How much amount of acetylcholine are you liberating? Almost 125 into 4,000 to 10,000. So this much amount of acetylcholine is liberated with one adequate stimulus, which will then bring about a sufficient end plate potential to complete the action potential, right? And the packet of acetylcholine which is released is also called as the quanta of acetylcholine. This acetylcholine receptor is a pentamer. Okay, so this comes as an MCQ. Pentamer means having 5 subunits, wherein there are 2 alpha, 1 beta, 1 gamma and 1 delta. And acetylcholine binds to which of the portion? So remember that acetylcholine binds to alpha subunit. So 2 acetylcholine molecules are going to bind to this alpha subunit to bring about a change in the permeability of the ions, right? So what did we see? That there is a presynaptic neuronal portion, a synaptic cleft, and the postsynaptic portion, which is the muscle end plate thrown into folds. There are voltage gated calcium channels presynaptically, ligand gated acetylcholine channels postsynaptically. The synaptic cleft, which is filled with ECF, will have calcium, and it will also have the enzyme acetylcholine esterase. Now let's see the events at NMJ, or how do you develop this end plate potential. So I told you that the motor axon, it is getting stimulated by, so this is my alpha motor neuron, right? And the corticospinal tract has lodged over it, either directly or via the interneurons, and it stimulated the alpha motor neuron cell body. So just this is the cell body, and now this is the terminal, and this is the axon, and this is going to be your NMJ, right? So you have to excite this portion. So the action potential is traveling. So the action potential, it travels along the axon. Action potential, it travels along the axon, and it reaches the synaptic knob. It reaches the synaptic knob. As soon as it reaches the synaptic knob, it is a potential. The change in the membrane potential is going to result in the opening of the voltage gated calcium channels, right? There is opening of the voltage gated calcium channels, and there is going to be influx of calcium. Once this calcium comes inside, this calcium helps in the release of the vesicles. Okay, it is actually going to take up those vesicles to the release sites and help in the release of the vesicles. By what process acetylcholine will be released? Acetylcholine will be released by exocytosis. So this comes as MCQ. Exocytosis, remember what it is? It is a kind of a vesicular transport. Now once this acetylcholine is released, it will bind to its receptors. These receptors which are present on the muscle end plate. Now as the receptors will bind, there will be a conformational change, opening of the channel, and the channel is negatively charged from inside. Okay, this protein channel is negatively charged from inside, so it is going to favor cations. Actually, if you see, sodium and potassium both can enter. However, the permeability is more to sodium, so more amount of sodium influx will be there. This sodium is a positive ion. That means the negativity, which was initially minus 90 millivolts, will now be neutralized. It will be reduced, and this will result in development of the end plate potential. Right? It will result in the development of this end plate potential at the end of the NMJ, which will actually then be converted into an action potential and go all the way through the muscle, which we will see. Right? So these are the events which are taking place. So whenever you get a question on NMJ, I always request you that to draw or to make flow charts. Don't write your answers in paragraphs. That is very, very boring for the examiner to correct. Always write physiology in the form of flow charts. Now, this you can see that this is your acetylcholine gated channel. Once the ligand binds over here, this is the acetylcholine which is binding, resulting in the opening of the channels which were initially closed. Sodium can now come inside. Once the sodium comes inside, that means positivity is coming inside, and this positivity is going to convert a local potential into an action potential. This end plate potential is very, very unique. Normally, if you remember, action potential is self-propagatory, but the local potentials, they are not self-propagatory, isn't it? They can be hyperpolarizing, they can be depolarizing, but the unique feature of the end plate potential is that it has got a safety factor. What is that? A single action potential in the motor axon. Okay, that means one EPP which we are producing by a threshold stimulus, that EPP can create the potential about 70 millivolts. That means it is having the potential to reach the threshold of that muscle fiber and convert that EPP into an action potential. So suppose this is the EPP, it will be converted into an action potential. So this is the unique feature of the end plate potential at NMJ, that it has got a safety factor, and that end plate potential can be converted into an action potential. Now, why do you need this action potential? Why did you want to develop an action potential at the level of NMJ? See, this action potentials from the level of NMJ crosses all the way to the muscle membrane. That is, it crosses across the sarcomere. You know that in the skeletal muscles, the sarcomere, they are forming the sarcotubular system, isn't it? Wherein the longitudinal tubes, and these are the longitudinal L tubules, and these are your transverse T tubules. These transverse T tubules have got DHP receptors, that is dihydropyridine receptors. Dihydropyridine receptors, which are nothing but which are the voltage sensors. So these channels will open, and by a mechanical configuration, just like a lock and key action, they are going to open this calcium channels in the terminal cisterns, that is in the L tubules, and the calcium will pour out. This calcium, what is the role of this calcium? Why do we want this calcium? This calcium will actually bind then to the troponin C, and the troponin tropomyosin complex will be disassociated, or it will be shifted, displaced. so that the active sites of actin can bind with myosin to cause cross bridge activity. So ultimately what we wanted was, we wanted some kind of an electrical event to take place at the NMJ, because we wanted to set up an action potential so that this action potential can travel all the way to the muscle, right? And it can open the DHP, that is the voltage sensors, which can then open the rhinodine, that is the calcium channels, make the availability of calcium to bind to troponin C, and ultimately what did we want was the cross bridge cycle, that is muscle contraction. So this was an electrical event which actually led to a mechanical event. That means what did we do? We caused action potential, that is an electrical event, that means excitation, which resulted in the mechanical event, that is the muscle contraction. This is what is called as excitation contraction coupling. So if you get an answer on excitation contraction coupling, it is going to be different from the events at NMJ. The events at NMJ are up till the point when you develop the action potential. That means when the local potential, that is the end plate potential, is converted into an action potential. Now never forget the fate of the fate of acetylcholine. You never want that acetylcholine should remain there only. Most of it can be removed by diffusion, but there is an enzyme, that is acetylcholine esterase, which will dissociate or break up this acetylcholine into acetate and choline, right? Into acetate and choline, so that the continuous activation does not take place, right? So this is the events at NMJ. We can just summarize this. So we have to know what about NMJ is something which is presynaptic, then the synaptic cleft, then the postsynaptic membrane. Here are your calcium channels, here is your acetylcholine channels. These are voltage gated, these are ligand gated. This will actually increase the permeability to sodium, develop an EPP, that is the end plate potential. Now if you enter every you can get a 2 marks BAQ. What is a miniature end plate potential? A miniature end plate potential is because of the release of very minute quantity of acetylcholine, which cannot cause efficient action potential but just a spontaneous depolarization, but never a true action potential. So a miniature is because of less quantity of acetylcholine. Now how can I correlate this topic with pharmacology? See, many of us, we use the skeletal muscle relaxants. So these skeletal muscle relaxants, what are these? The skeletal muscle relaxants are drugs that act either peripherally at the level of NMJ or centrally in the cerebrospinal axis to bring about muscle paralysis or to decrease the muscle tone. And these are especially used along with the general anesthetics when you have to provide muscle relaxation during surgery, or when you have to treat painful muscle spasms and spastic neurological conditions. So you can make a very simple table for yourself at the level of first prof. You can remember the drugs acting at NMJ. For example, the botulinum toxin, which brings about the blockage of release of acetylcholine. Curare, which competes with acetylcholine for receptors on the motor end plate, that means decreases the size of EPP. Neostigmin, which is anticholinesterase and therefore enhances the duration of action of acetylcholine at NMJ. Drugs like hemicholine, which blocks the uptake of choline and therefore depletes the acetylcholine stores, because once the acetylcholine is degraded, choline will be taken up for recycling and for further synthesis of your acetylcholine. Now very interestingly, baclofen, a very common drug which we take for muscle spasm. It is also a kind of a muscle relaxant which simply acts on the GABA B receptor. It is the GABA B receptor agonist, and remember, both poly and monosynaptic reflexes can be inhibited. It is a very strong and effective muscle relaxant. Now let's take another history. If a patient comes to you with an eye complaint, that is drooping eyelids, so this can be the clinical picture, that this patient is coming with drooping eyelids, which we called as ptosis, right? Then the history reveals that the woman has got generalized weakness, fatigue that improves with nap. So again, improvement with rest is a very important feature, right? So this patient was then investigated for ptosis, and also there were circulating antibodies present. The moment you find that there were circulating antibodies to the nicotinic cholinergic receptor, your diagnosis of myasthenia gravis is confirmed. So what is myasthenia gravis, boys and girls? Myasthenia gravis is an autoimmune disease, basically a neuromuscular disorder which is characterized by weakness, by fatigability of the skeletal muscles, which weakens or worsens with more usage. Like in the case history which I had given you in the beginning, the patient saying that she has got more difficulty in chewing non-vegetarian food, and the moment she takes rest, she feels better and then she can chew again, right? What is the pathology? Here there is no problem with the release of acetylcholine, which is normal. It is mainly because of a decrease in the number of the acetylcholine receptor. Because the number of the acetylcholine receptors are less, you don't get a sufficient EPP, that is end plate potential. When you don't get a sufficient end plate potential, you cannot reach the threshold for the action potential. And if you do not have an action potential, that means an electrical event, you cannot get a mechanical event, that is muscle contraction. So circulating antibodies are very, very important feature. These antibodies, what do? They either bind to the acetylcholine, right? They compete with the acetylcholine to bind with the acetylcholine receptor. They can bring about endocytosis of the acetylcholine receptors, or they can even damage the postsynaptic muscle membrane. Clinically, the most important feature the patient will come up is fatigue. So extreme tiredness, okay, fatigability. The patient says that he feels better in the morning. That means when he wakes up, he is better. But towards the evening, the complaints increases. That improves with rest is a very, very important clinical feature. Ptosis, respiratory muscle paralysis, is a very, very important and a dreadful complication. That means the facial extraocular muscles are very commonly involved with myasthenia. Remember that females are more subjective than males. So it is more common in females, especially in the age of 30s. What is the physiological basis of treatment of the disease? This is a very important question, as a question that comes to you for writing also. So first important thing which we have seen, that we will give anticholinesterases, for example neostigmin, which will prevent the degradation of acetylcholine and prolong its duration of action. Second important thing is, that the cell processing, especially the T cells, are done in the thymus. So you can go for a thymectomy. You can bring about immunosuppression, suppress or decrease the immunological response by giving immunosuppressive drugs like azathioprine. Finally, you can do plasmapheresis, which is the procedure where you can remove antibodies, right? So the question when comes that what is the physiological basis, you should know that why a particular drug is done, how it will be acting at the level of NMG. So suppression of the immune response, removal of the antibodies, this is what is expected physiologically, so that you are able to correlate it with the form of treatment that is given. Now just wind up with few MCQs. What is the width of the synaptic cleft? A, B, C, D. Obviously it is between 50 or 40 to 100 nanometers. The specialized part of the sarcoplasm is Presynaptic membrane, end feet, motor end plate or palisades, it is motor end plate, and therefore the action potential or the local potential that develops is called as the motor end plate potential. So boys and girls, again in a nutshell, NMG is nothing but it is a chemical synapse. The three important diseases which you should remember over here: Myasthenia gravis, botulinum poisoning, and when there are antibodies against the when there are antibodies against the calcium channels. Okay, when there are antibodies against the calcium channels, it develops something which is called as the Lambert-Eaton syndrome, which is also a kind of a muscle weakness where there is more involvement of the proximal muscles of the lower limbs. Right? So boys and girls, I request you to please definitely put on a comment, did you like the lecture and what else you need, right? Your topics you want to study more. In the beginning of the lecture I have given a link. That link was for my Telegram group, that is Synapse for Success in Physiology. You can find me on Telegram as Dr. Reena Kaur Ruprai. You can message me personally. Please communicate on the group. Do share, like, subscribe the channel so that we can really have all the wonders of physiology. Happy learning. Stay tuned. God bless you. Thank you.